Welcome everyone to another session of Candid Craic. We'll probably need another episode to explain what it actually means, but today we have Nidhi. Nidhi, how are you doing?
I'm good, thank you. Thank you for having me.
Tell me first a little bit about your background, and then we'll actually start.
Okay, so I'm Nidhi Goel. I'm a psychiatrist, a mother of twin toddlers, and I live in New York City right now, isolated with my twin toddlers in an apartment and working on a startup, HealMed.
Explain me a little bit more about this startup.
Sure. So I have worked over a decade as a psychiatrist in acute care and in long-term care, treating severely and persistently mentally ill patients. I've had a fancy practice in Chelsea in Manhattan, and there's a consistent problem where mental health or illness, disease burden is exponentially going up, and on the other end, there is severe shortage of provider. Where 60% counties in the United States have 0 psychiatrists today. And this is going to worsen further. To add this insult to the injury, another 60% psychiatrists are going to retire in the next few years. So all this, what does this mean is that patients take at least 4 to 6 months to get their appointment. And in world of mental health, when a person is suffering from severe depression or suicidal thoughts, they need help now. So essentially they go to emergency room to find some help, which again is a very frustrating experience where they'll wait from hours to days to get some sort of help. And the symptoms today, they escalate into full-blown disease and eventually disability. So humanly, today, I feel there is no way we can bridge this chasm of severe shortage of provider and increased need of care. So I came up with this idea to see if digital health can plug in, and created a company called as HealMed Solutions, where we have a digital app which is driven by artificial intelligence. It does a comprehensive evaluation of a person, essentially just like what I would do when I meet with my clients first. Whole comprehensive history, your chief complaint, history of present illness, social history, your family history, psychiatric history, medical history, and then transcribe all that in the real time into a transcript which a provider on the other end can then see in a very color-coded visual manner to determine the diagnosis or the therapeutic plan from there on. So essentially 80% work is automated for providers to to make them more efficient. And on patients' end, it starts their treatment journey in an immediate manner, essentially. So that's the brief synopsis of what I'm doing.
So does it, Nidhi, when you say it charts their treatment, I mean, does it give you full psychiatric breakdown and do this, or when you say treatment, is that a wider range of things that it might be able to do?
So what my system is, it's a clinical decision support system, CDSS. It's not diagnostic or therapeutics. So we leave that diagnostic and therapeutic part for the provider for which they're trained for and what they enjoy doing. What's happening in today's world is we spend, let's say 45, 60 minutes to get comprehensive history from a person, right? We need to understand them as a whole person. And then we spend another 30, 40 minutes or even an hour typing up that whole history because charting is required. So essentially in 2 hours, we're seeing one individual person. So in a day, we can max see 12, 15, 20 patients. So this system would do the whole history taking in a very sort of a standardized manner that it's very comprehensive. It's not rushed. It's at patient's pace. And also transcribe does the charting part, which a provider would do. So now provider can essentially spend all their time in a very meaningful way to have discussion with the client about their diagnosis and what therapeutic alliance need to happen rather than just spending last 5 minutes of their session discussing that. So diagnosis and therapeutics is still on the provider rather than on the system. Does that make sense?
Yeah, it does. So what So one level, you're saying that there's a dramatic shortage of psychiatrists, and that'll get worse. And at
Correct.
the same time, there's a fair amount of research showing that people are struggling more and more with mental health, and there's going to be more likely that more and more people are going to need psychiatric help, and you're plugging that gap in right. For every person, there's 2 hours of admin, and we can reduce this to allow the psychiatrists, the fewer and fewer psychiatrists, to have more time with the people. So in essence, you're doing that, yes?
Correct, exactly.
So this still doesn't necessarily solve the challenge of if everybody who goes through it has to have psychiatric treatment. Because they're still with a shortage of psychiatrists. So does everyone who go through it need psychiatric treatment, or do other things happen as well?
Wonderful question. So we have different products, right? So one is for the healthcare system, where a patient takes the assessment and provider has the thing. So the workflow is done. Then we have a product for consumer, where a consumer sitting at home, let's say employee at work, right? Burnout is a important problem nowadays. Work from home has isolated people. They're now taking care of their kids, virtual schooling. They may open their wine bottle at 12 noon, and by the time their workday is finished, they're already down the bottle, and then they're so irritable, they're either yelling at kids, throwing their toys, kicking their cat, or whatever they're doing, without understanding what's happening to them, right? So they don't know they need help. Everyone around them is miserable. They are miserable, but they don't know that they need help. So if they would take this assessment, it can categorize them based on color coding. We are not labeling anyone with any diagnosis, but it can tell them their risk. Okay, you are in green zone, you're okay, or you can do XYZ, or you're in yellow zone, you need some extra steps or be mindful of certain things, be it yoga, meditation, taking a break and walking out for a few minutes, or breathing for 2 minutes. So those sort of different care plan. Or you're in orange or red zone, where you need to seek professional help. So that's a consumer product, which a person can identify the need to seek help, need to take care of themselves. I'll give an analogy. We all know sugar is bad for our health, right? So, but we still give in to our temptations, right? Unless a provider tells you you are pre-diabetic, your hemoglobin A1C is 5.7, now you're like suddenly, oh, I can't eat sugar. So that sort of way, if someone tells you, or HealMed tells you, hey, you are at the brink of yellow to going to orange, do something now to prevent actually walking into that orange or red zone, you are the more higher chances for you to actually do something, rather than just, again, a next day comes where again you're opening your bottle and the day passes by. So that's a consumer product.
So it's a kind of an attentive responsibility. So you've gone through this. Please attend to this. We've identified the things you need to attend to before you get worse.
Correct.
So please take responsibility, and you can do all of that at a scale that you could be helping everybody, a vast number of people get a sort of stay well enough to not need psychiatric help, which is another way that you could impact the fact that the shortage of psychiatrists. Is that right? Yeah.
Right. So health or well-being has different components. I try to break it down into different level of prevention. So one is, although there are 4 primordial, but that's not applicable to us, primary prevention, secondary, or tertiary. So the primary is what can we do to prevent getting into that illness zone. Secondary is where we screen in timely manner, where again, if something is just a symptom today, will not become a full-blown disease. And tertiary is, again, when the things are so bad that now you need rehab or proper disability help, right? So at what level, if we do something, can we prevent getting to that final level of care, or tertiary level, where in the United States, 90% of $3.8 trillion Medicare budget goes to people with chronic medical conditions and mental illnesses. So much money is draining in just one arena, versus if we spend time, money, and just focus on that primary level, maybe we can prevent all that extension of disease, full-blown disease. So that's where my thought process is, and it's very affordable, simple, and accessible mean where someone can be sitting at home, download an app, do the assessment, know in timely manner, Do they actually need to do something? They be more aware of themselves, essentially?
So I'm going to ask you to make an educated guess here, Nidhi. So if say this people are going through this kind of do you call it triaging or whatever you would call it to whether you need psychiatric or professional help. What kind of percentage of people perhaps are we talking about that you could prevent going into those tertiary or red zones? You know, is it 20% of people that you'd be able to stop getting there, or is it a larger number?
If you had asked me this question a year ago, my answer probably would have been different. This COVID pandemic has changed metrics so much. In 2019, we used to say, or WHO metrics, 1 in 5 person would suffer from mental illness in any given year, right? So 20%. In 2020, by June, US surveys showed 40% people, adults, were reporting depression or anxiety. And September was showing 60% of people are reporting depression and anxiety. And this is just a survey population, right? So metrics of higher chances, essentially today with unemployment, again, work from home, social isolation, racial tension, or election fiasco, if I may add in, and this, people are dying, relatives are dying, and people are not able to say goodbyes. We have dead bodies in trucks today, waiting to be cremated, and the grief, unresolved grief, because access to, again, care or social support is missing. Numbers, essentially, I say today, everyone needs it. Everyone needs to understand where they stand today. Are they just internalizing it? Are they becoming numb to it? Or something can be done if they realize that maybe they need to do something about their situation today. So
yeah, I'm just going to get my head around the numbers here, because they're quite dramatic. So see if I've got it. So based on current research, 3.8 trillion of the US healthcare budget is going on people needing tertiary care, and there's a high comorbidity between poor mental and poor physical health. So you can almost regard them as the same cohort. Since then, because of COVID, there's a potential that might increase by 3 times, from 20% of the population to 60% of the population. So we're now looking at 3.8 trillion, 12 trillion. At the same time, professional help is reducing. It's already not enough, but it's going to get worse because people are going to retire and nobody is taking their place. And if there's an absolute necessity for a solution that prevents or doesn't prevent, helps a lot of these people to solve their own challenges before they need professional help. And that's the space you're looking at, is right. Some people are going to guarantee, some of these people will necessarily need professional help, but an awful lot of these people, and we can identify them quickly and solve a lot of the time pressures that the professional community has in relating to this. But we've also got all of these other people who are showing early stages of this that we can also help to prevent them actually getting to that stage where they need professional help. So is that, and it's a $12 trillion kind of problem.
Correct. You're absolutely right. So we realized in this pandemic, right, how fragmented our healthcare system is, right? It was so obvious that we didn't have masks, we didn't have proper PPE to care for people with COVID. Mental health pandemic is here. It's right in front of us, and we are absolutely not ready to deal with it. We are unable, and we are simply closing our eyes towards it. We don't have resources. We are not paying enough attention to what to do. So this tsunami of patients, when emergency room, which is now dealing with COVID patient, will see all these patients come to ER for their mental health need. How will we manage that? What are the answers for that? Last 2019, 40% adults went to ER for their mental health needs. That is 40 million people. 40 million people went to ER for their mental health visits. alone to emergency room. And currently emergency rooms are, again, not even doing elective different surgeries. They're only dealing with either trauma or COVID patients. How are we going to deal with high suicide rate has gone up? Suicide rate has gone up in healthcare providers. Psychiatrists used to be high risk for suicide. Now ER physicians that are high risk of suicide. So this is such a massive problem today, Richard, that something needs to be done, and something needs to be done now. We are already very late in it. And if we don't pay attention to it, exactly like you in dollar amount, you said $12 trillion, I would say more than that, essentially, that we're looking at.
So this is a level of cost that's going to bankrupt America.
Or globally, I should say. It's not just America. I mean,
yeah, okay, even worse.
Talk about India. India needs 90,000 psychiatrists. We have only 3,800 psychiatrists. Talk about Japan, 80% increase in suicide rate last year alone, especially in women. And women are sort of marginalized, I shouldn't say, but they're taking care of kids, higher rate of unemployment in women. So talk about Canada, talk any country you take at this time, every country is struggling with this tsunami of mental health disease burden and shortage of providers. It's a global problem.
If you look at the technology, it's an assessment tool, right? The way I understand it. So give me some context where you would fit, because Richard described how big the problem is. You're aware of this as well. And you have this assessment tool. But do you also then provide a solution of how to help people?
Yes. So, like I said, we have two different programs, right? One is for specific healthcare industry, where a patient who has to wait 4 months or 6 months. So collective population health, if you have so many people in a population who have higher mental health illness and not getting treatment, society pays the price, where suicide will go up, or violence will go up, or domestic abuse, substance abuse, a lot of things will go up. So can we give them this app to take that assessment instead of waiting 4 months? Now they can be seen next week, because essentially time to provide care is 10 minutes rather than 2 hours. So each provider should be able to see higher number of patients, and patients should begin their treatment engagement journey immediately rather than waiting again 2 months or 4 months or 6 months. So that's the benefit in healthcare industry side. There are many verticals. In United States, if something happens and 911 is called and cops go there, either they will bring that person to correctional facility or to emergency room again. Can we give them this app to do the assessment, and then a triage person determines whether a person should be brought to emergency room, or can they follow up on outpatient basis? How much resources we can save there? Then coming to employee benefit in companies nowadays, if a general population metrics is 60% adults are suffering from depression or anxiety, there is another statistics where 96% managers said that their team has very high rate of burnout, or a stage before burnout, which is fading out. So essentially, metrics are there that people are suffering. So if 1,000 employees are there, 600 are suffering from depression or anxiety. You can very well imagine performance, productivity of that organization. So can we give this to their employee to take an assessment at home, in privacy of their home? Either they can do touch-based or voice-based. The difference of my assessment is it's not 4 choices out of, like, you choose 1 or 2, how's your sleep, 4 options, how's your appetite, 4 options. It's a dialogue. It's a dialogue where one question can be answered in 10,000 different ways, right? One question can be answered in so many variables. Then how do you determine what's the next question? That's where our 18 months of time went into designing that intent for that. And we have I'm very humbled that we have applied for IP. We have 86 claims in that sphere. So that's where our energy went. The dialogue, where answer can be anything and a person has full way of expressing themselves. We are not telling them to type their answer, because many people may not be able to express as well in typing their answers. It's free flow, speak what you want to, as much as you want to, and still be able to take a comprehensive assessment in privacy of their own home, and then see a care plan based on their individual needs, whether they need help with substance abuse, whether they need help with some sort of trauma, anxiety, again, panic disorder, whatever you call it. Does it answer your question? I know I went to the long-winded.
Well, I've got two follow-on questions. The second one is going to be about the use of AI and tech, but I've got the first one I think is more immediately pertinent. So you just talked about fade out and burnout. So for me and the research that I do, so burnout, when you're burning out, you've then got the risk of breakdown. So the psychological breakdown, but also something that's called escape attempts. And so escape attempts can be anything from the addictive, turn to opioids, turn to drink, turn to porn, whatever it is to give you these dopamine hits and things. But it can also be permanent escape attempts, suicide or homicide at work, or just get rid of the thing that's causing you this stress permanently, which is obviously hugely problematic. And I think we see a fair amount of evidence of this going on around the world. I don't really want to talk about that. I want to talk about fade out, because you've just said 96% of managers are reporting that their team are experiencing fade out. So what is fade out, and how can your interventionary technology stop fade out from going into burnout and all these dystopian outcomes?
Right. So the concept of feeling numb. So there is absenteeism, right, in a company, and then there is presenteeism, where a person is present but still so numb to what's happening and just on spinal level doing their work. At that level, where something is obviously wrong, that you have made yourself numb to reality around you, and when it comes out into, like you said, escape mechanism, whether you're just numbing yourself by drinking, by using drugs, yelling. Domestic violence has gone up hugely today, and then how do you again, when you're so numb, how do you know that something needs to be done? So a lot of apps have come into market where people with CBT component to it, essentially they're chatbots, or productivity measurement things, or how do you improve your this. But if a person is so sort of faded out or numb, and asking them to jot their productivity metrics or do this or do that, think about yourself, how inclination you'll have to actually go and log into that app and document that, right? That fear of judgment. If I don't log, I'll be judged. If I log, I'll be judged. So after a week or two, it fades out. What my app is doing is not saying anything that I'm there to treat you or help, like increase your productivity or provide you therapy or anything. It's simply assessing the need. Do you think you may need help? Do you think something may be happening to you which you are not recognizing because you're so numb or just avoiding to feel it? Do you think your family may be getting the brunt from you being that numb or faded out, essentially, or heading towards burnout, like you said, and then all those consequences? Can we assess that need today? And can we then take some appropriate steps? Be it just, again, like I said, simple things, remembering to drink water, remembering to take a break, get out from your chair, walk out towards sun or outside for a few minutes. Just take that break, take deep breaths. Essentially, we say breathing is the best thing, right? We all are breathing. But how many times do you remember to take 2 minutes of that just breathing, just deep breathing? So, but if you know your need, like I said, if you know that sugar is bad, but if your doctor tells you that sugar is bad for you, if you don't do something now, you will become diabetic. More likely, higher chances. I'm not saying everyone will do it. Again, higher chances of you to maybe pay attention to it, or maybe your family will support you, or something can be done at that level. Can we do it at individual level, or why I'm saying organizational level, where if HR department is giving this option to their employees, hey, we have this for you. If you think you need help and it's taking you 3 months to find a therapist or psychiatrist, maybe take an assessment, understand your need today, and see where it leads you. That's all. It's very simple concept here.
So you're sort of opening up, I guess, attentive windows of coping within that numbness. You say, okay, and these might or might not work for you, but let's try and turn them into habits to instead of the numbness sinking into burnout, that you you get some feeling back, you get some humanity, you get in touch with your emotional self again, and you feel in control of your emotional self. Because I've also heard from a coach that I've worked with, when they were trying to do emotional work with their client, the client only understood one emotion, and that was stress. Every other emotion was overpowered by stress. So I guess you've almost got numbness and stress here as a Scylla and Charybdis of pain. Either you numb or you become so stressed that you can't cope. Both of them are problematic, and you can deal with that space.
And the word you use, stress, like so many people will express stress in such different manner, right? Stress for me may be that I feel some acidic tinge in my belly, on my stomach, right? Stress for some people maybe that their heart rate starts to race fast. Stress for some, they sweat out so much. And stress for some people, maybe they just ruminate about something that their boss said or their spouse said or their colleague said, right? So stress is so different in expression for different people. But it's just one word, stress. Either you're feeling it physically or psychologically, or you're numb to it. That's the way people are dealing today.
Okay, so I now understand the power of what you're trying to do and the vision. I mean, I can see it, and I can see the potential difference it can make. So now I'm going to ask the tricky question. So one of the workshops you ran for us, we had this come up. Someone from a demographic slightly older than you and me suggested that they would find it very uncomfortable talking to a machine about their mental well-being. So the problem of artificial intelligence and the demographic that says, no, I want to speak to a person. How are you dealing with that?
And this question comes a lot, right? In the world of psychiatry or psychology, I should say, people are so much into this human contact, human rapport building, affect, and all those concepts, right? So, but my, again, first question is, if it's not available, if therapist or psychiatrist or help is not available, do you rather wait 3 months to see someone, or would you, after a month, feel, okay, it's better to speak to an app than not get any help at all, right? So it's a simple math today where, again, when these 60% workforce will walk out, what will happen then? It's happening now. 6 months of wait time to see a provider, 6 months of wait time to see a provider. So that brings me again back to the thing. Even in emergency room, many providers ask, what if patient refuse? I'm like, let them refuse. They can choose to wait for a day, 2 days, and sitting in ER waiting to see a provider, versus then they can choose to at least get the process started by talking to an app. And we have created it in a very like feminine, human-like voice. It's not human voice, but human-like voice. And we have a lot of sort of encouragement words there. It's at their own pace. You're doing well. Can I help you? Like a lot of words are there in that manner to help patient glide through it. And if they feel tired, they can pause. I'm not saying everyone will like it. People don't like to talk to me, right? Sometimes a patient may come to my door and say, hey, I want to go and smoke cigarette first. It's a real life scenario. They may choose to say no to app. They may choose to see a provider. People have preference to see what kind of provider they want. They want a Black provider. They want a female provider. They want a white provider. So everyone has so many different choices, and they can choose not to speak to it, just like their providers.
Yeah.
So the one thing that I'm interested in as well, Nidhi, is you've been running this tool assessment for a while. What, I don't know if you can share this, but have you seen particular trends happening, the way people use your solution?
We are still quite a new company in the space, I should say. But certain things, and it's a silver lining in COVID, that COVID has put some tailwind to us, where people are much more open to virtual experience and digital experience. And even in elderly population, they're very happy to use app or virtual care today, because they're afraid to go in provider's office, essentially, with fear of contracting COVID. So it has suddenly opened up a huge, vast acceptance for us in a manner. So like I said, silver lining in COVID, people are much more open. The fear of judgment is not there. People are open about their sexuality, their gender identity issues, their substance use issues, because there is no human on the other side to judge them in the moment. So evidence is showing that people, even in standardized scales, that if done in digital app versus done in presence of GP, higher accuracy with assessment done in digital app. So trends are showing favorably. Evidence is showing people are much more open to apps in actual accuracy of assessment. And the last thing, and again, in the world of psychology, psychiatry, where rapport building is a thing, imagine a patient with the mask and a provider with a mask sitting in a room 6 feet away. What sort of rapport can happen? So it's much better when they're talking virtually. An app is not the end of it all, right? If assessment is done in the healthcare segment, again, there is a video teleconferencing built in where a provider can then have a meaningful conversation based on the history already assessed, where if someone is saying, I wanted to buy a gun to shoot myself, now provider can focus on this aspect of care more in depth rather than just rushing through the interview.
So I think your app is destroying the plot of House MD. I don't know if you ever watched that, but I mean, the whole premise of House was that everybody lies. So, you know, when you're trying to do the diagnostic, he works on the base assumption that the patient is so afraid of being judged, they're going to lie about everything. And then he has his little team of 3 people that go out and explore and find out what the lies are about. You're actually saying that that's less likely to happen when you're using an artificial intelligence or a tech tool or assistive intelligence, whatever you want to call. So not only is the initial triage quicker and it gets rid of all of the pain of doing the admin, it's more accurate. And so you can see clear trends in it being more accurate, or people providing stuff earlier that might take a number of sessions for them to talk about in a face-to-face.
Exactly. And in face-to-face, there's so much also concept of transference and counter-transference. What I may diagnose someone, or what my opinion about someone's condition could be entirely different from someone sitting, or someone other provider, right? Because there's that individual transference, counter-transference that plays role. But in an app, it's much more standardized because it's standardized. So I'm actually hoping we are sort of pioneer in the space that we will have that centralized data. We may question, how are we plugging all these people? Every individual is different. Every individual circumstances is different. How are we plugging them in 15 different diagnostic boxes just based on the current trend that we have, current world of healthcare we have? So I don't have that data today, but 5 years down the road, once we have more and more assessments done, we may actually be sitting on it and then analyzing. Standardized way of getting information at patient's own pace, at patient's own judgment level, and all those things. Will that change?
And could you also talk a little bit more about the let's say the user behavior, the journey in terms of an illustration? So let's say I use this app, right? So how does this start, and what are then the next step? How have you structured this?
So the app is available on iOS and Android. So it's HealMed and people can download it, but they can't do anything with it, until unless either their organization gives them a code, as an organization code and a unique ID assigned to each person, or again, if it's a healthcare facility, after registering for an appointment, then they release that code. It's alphanumeric code and unique, like only 1 in billion, so nobody can repeat it. Nobody can go back and forth. So if you open an app, you can't do anything until unless you have that accessibility. So it's very secure in that manner. And even if you have done the assessment, nobody can see that assessment until unless you provide a credentialed person to look at it. So a person has to authorize someone to look at that assessment, the transcript. There is no way for someone to bypass the question. There's no way for someone to go back and forth. So it avoids all that. It's just a dialogue. Like you and I are talking, words are spoken, words come out, they're recorded. And the next question will we have hundreds of thousands of questions in the library. So it's not like, again, this logic flow of this will come, a second will come, a third will come. It's a dialogue. And that's the uniqueness of our platform. And once the assessment done, again, either the care plan will come if it's a consumer product, or if it's a healthcare, then they will get to decide your mental status exam, and your diagnostic and therapeutics will start from there.
But how does it decide to, let's say, you start with an opening question? How does it decide what is the next question?
So intent. So when it opens, it introduces itself. Hello, my name is HealMind. I'm here to assist you. And then it starts. So how can I help you? Right. So that's an open-ended question where a person may say, my spouse yelled at me, or my boss yelled at me, or I'm feeling depressed, not sleeping, or whatever it is. Right. And the flow, there is some logic to it, but the intent of your answer will determine. And having said that, we still have built it in a manner where it will assess all the categories that we need to. So categories meaning your mood, your anxiety symptoms, even assessing for psychosis or trauma, somatization, essentially, even social media use or gambling issues, whatever it is, the whole gamut of it, and the personal history, of family history, social history, everything. So that's the beauty of it. And if someone is so disorganized, let's say I asked, how's your appetite, and you answer tree, apple, brinjal, whatever, it will still bring you back to the question, a simple binary form. Can you please answer this in yes and no? So it's designed keeping that a severely ill person should be able to take it, but a high functioning person can also breeze through it. So it's a very complex process.
it sounds very unique to the individual. So the individual's taking it, and it branches off into the various different things that individual needs to talk about as you go further down the journey. Is that correct?
Correct, but still able to bring you back to do the whole thing. What happens in real world, if I'm just talking about suicide, I can spend an hour talking about suicide. And when the patient leaves, because time is limited, then I'll be, oh gosh, I forgot to ask about allergies, about medical history, or about this or that, right? So this app will still do the comprehensive eval, but giving you opportunity to talk about what you want to.
It's a bit like how this interview works, whereas Oscar keeps us on track and makes sure that we go through all the stages we're supposed to, and I wander off in all kinds of directions and give you questions you're not prepared for.
Exactly.
Okay.
And then at the end, you get a sort of very comprehensive kind of report that a professional can use. And it's up to him or her to have this interpretation of, okay, what's next.
Yes. So if you're talking about the professional, they will have two ways to look at it. One is their dashboard, where all the symptoms will be clubbed in color-coded manner. No abnormal finding, critical finding, alarming finding. And then a comprehensive verbatim report. Again, it's verbatim. What happens sometimes in a private medical practitioner, a patient may go and say, hey doc, I haven't slept in 2 weeks, and I was thinking of, again, buying a gun to kill myself. Now this doctor who knows how to treat blood pressure or diabetes will be stuck. What should I do next? So they end up calling 911. And when a person goes to the ER, they're like, I never said that. And this doctor is accosted, and this patient is like, because they're frustrated sitting there for hours, they have to go back home. So because this history is verbatim in patient's own words, so that medical legal liability is cut down. And we have a consistent report what patient said in a primary care office and what patient is presenting to ER. Now, if it's a consumer product, that history, that verbatim report is available in cloud, but it's not accessible to patient unless patient authorizes, or person authorizes it to send it to the designated provider. What a consumer will see on their end is their care plan. We are not labeling anyone. We are not saying you are unipolar depressed or bipolar depression or mania. No labeling here, just the care plan. We saw some risk. We didn't see any risk. We saw critical risk. Okay, if you do need to see a professional now, rather than, again, just labeling a person with diagnosis and then leaving them with in lurch what to do next, because that appointment will still take 3 months. That's the idea.
So I mean, so at a societal level, I can really see what you're trying to do here. So the socioeconomics of this are huge. and you can really see what the impact would be, and also at a professional level, you know, that the psychiatrists are going to be significantly helped by this. But what the other thing you've talked about is you know, organizations buying this or using this. So what about the organizational level? Now, I have my own ideas around this, but what kind of discussions are you having with organizations as to why they should get involved with this kind of product and this kind of way of evaluating health?
Right. So in today's world, the metrics, I mean, of course, the United States has metrics for everything. Most expensive benefit organization has to pay for their employees their healthcare insurance premium. And that healthcare insurance premium is more expensive than even paid leave for an employee. And that metrics or the premium changes year by year based on how many employees used sick days, access to healthcare. And if a employee is burned out, they have higher chances, or stressed even, they have higher chances of going to emergency room for medical issues, 23% more chance to access healthcare system, and calling sick days, and even leaving the job, right? So all these metrics, which again, go back to organizations where either they're paying higher premium or higher attrition rate, which essentially means brain drain, training drain, and higher cost of rehiring someone else. At the cost of, by the time you recruit someone, your remaining task force is overburdened, and subjected to, again, higher chances of burnout. So this whole vicious cycle that plays, versus how much dollar amount organizations assign towards wellness program, if I may, or again, giving some sort of mental health help, is drastically different. So $3 to $6 are assigned per month for wellness programs, as compared to $300 or more for premium, a monthly insurance premium. So can we talk to organizations, hey, if you spend instead $30 per month on wellness, and then you have to essentially will be paying $250 eventually on premium if your employees are well. So and if surveys, general population are showing 60% adults are reporting either depression or anxiety, that means if you have 1,000 employees, 600 are potentially having some sort of issues right now. So all these metrics, that's how we start the conversation, and that's what we are trying to tell them. See price you're paying upfront, or the cost you will bleed, like how you're bleeding, essentially. Does that make sense? So a lot of awareness is happening. People are understanding. Organizations where it was taboo to talk about peers' personal life, now organizations are sort of saying, okay, please check on your peer, ask them how's their family life, what's happening in life. So things are shifting, but it's a slow process. Awareness, of course, is required, rather than, again, just answerable to your final number of the organization that we need to make. This is our revenue, this is our profit margin, this is this, and this is this. And asking your, one more metric, Richard, that I like to talk about, when we talk about stress in employees, there are different reasons why employees are stressed. Is it their workforce, is their family life, personal life, or workload? And workload is considered as the highest cause of stress. Each employee can effectively do a certain amount of work and have a quality of life work balance. But if employees are asked to do a higher amount of workload just to meet those targets for the organization, higher chances of them becoming burned out or leave the thing, right? So can organization think about this number and bring it down here where employees can effectively manage their workload, or hire more people to do that, is the question that they need to pay attention to. And where our product comes is, again, at the need, like I mentioned. If your employees are doing XYZ, they're drinking more or taking it out on their families, that means something needs to be done. Can we assess that need now, and something, a care plan essentially happens at earlier stage, rather than when thing has already, like you said, the worst part of it, either they leave their job or commit suicide, or you're waiting for class action lawsuit if something happens at workplace violence or whatnot. So, it's again very complex.
So I mean, I see why that would attract organisations, but I'm also interested if you ever get into the stuff that Oscar and I are sort of focusing on, which is the cognitive capacity to do good work. You know, we know that complex problem solving and critical thinking and creativity and cognitive flexibility and active learning, all of these kind of things are necessary to do the quality complex project work. And that's what the vast majority of knowledge workers are having to do. Is anyone interested in conversations around that? Because obviously, if you're struggling with your health, both mentally and physically, you can't do that work. So is anyone interested in your experience in talking about that part? Because it's a lot more oblique and you can't do linear, okay, this equals that. But is that a conversation that you're having?
We're attempting to, and thankfully, again, COVID and all these things that every individual, be it the C-level suite member or owner of the company or HR department, because everyone is human being and they all are going through the stress of COVID, which has made them more aware of mental health issues and suffering, essentially. So people are a bit more open to having discussions, at least. Now, what they would do with that information, I don't know yet, but at least they're open to having these discussions. And certain decisions are made on different level. Again, the labeling effect is there. People are afraid if all our employees again would find out that they have depression or anxiety, or they'll become more aware of this. So that fear is there, of course, that they will become liable, that your organization has made us this way or whatnot. So fear is there, which is, of course, but I think dialogue, communication, conversation, awareness, I'm hoping change would come eventually, or at least baby steps, I should say.
So the door's opened to these kind of conversations, but it's only a crack at the moment. You think it should be pushed wider open. I mean, and I fully agree. I mean, I think we're struggling to deal with the complexity of that kind of performance. We see everything in linear terms. So I absolutely understand why you're coming in at the monetary linear kind of level. I just would love to hear that any story you have in the future around, oh wow, I just had this conversation where they were talking about the cognitive performance and that kind of stuff. That would be wonderful, because I'd like to see that door swing open.
Well, let's see if I get some experience. I'll share with you.
Fantastic.
So where do you see, Richard already kind of touched on this subject a little bit. So if you look forward, right, or let's say the next 20, 30 years, it seems that, it's a timely launch of your solution. What do you see happening over the next 2-3 decades?
My dream is mass adoption and mass awareness of mental health. It has been on the back stove for a long time. Mental health parity law came into force very recently. Again, back to India, their first mental health policy was written in 2014. So it's still in infancy stage, and I'm really, I mean, especially with EQ Lab and you guys doing work in this and having intellectual conversation internationally, makes me happy to know that they have started talking about it. They're trying to spread information. They're trying to make some meaningful change. And in 2-3 decades, of course, mass adoption of this awareness and essentially schools. So education system, if we start early, where I said a metric of 18 million kids in the United States, which is 80% of children did not have mental health care access. If we can do something at that level, early intervention, I think we can have much better society as a whole, because mental illnesses do not just affect individual, it affects their family, it affects their neighborhood, it affects the community and the society at large. If someone picks up a gun, AR-45 or 15, whatever you call, and go for mass shooting, whole community suffers. So again, timely intervention, adoption, awareness, these things are important. We need to be talking about it. Avoidance and denial has been there forever, and it simply cannot work. We are paying price now.
You talked in the workshops we did about something called health equity. and that seems to interact with just what you've been talking about. Can you explain what health equity is and why it's important?
So health equity in the whole, again, population or community, it's a concept where it's not just individuals' inner resources or resources around them, it's community resources, timely access to care, intervention in timely manner, disease burden in the population, death rate, and the whole community resources that are available in a timely manner is important because, like I just gave an example of this health equity, one individual can cause a mass destruction. And if we collectively focus into population health or invest in, because we talk about all these organization level equity and stocks and whatnot in this health, well-being of not just individuals, the community as a whole, because societies have become so individualistic, and unfortunately, even in developing countries where that joint family concept or concept of neighborhood and village was there, they're also moving towards this individualistic society because of globalization, which is very, very unfortunate. And I think that shift needs to happen again back to community concept. So if we invest more in this community at population health concept, I think we'll have much cheaper way of dealing with all these things, where we are dealing at tertiary level of prevention of care. Does it make sense? It's like the
intellectually. So the way that I'm perceiving it is if you invest in the community, so you create a healthy community. And then out of that community come a whole bunch of people capable of doing flourishing and doing highly positive work and the cognitive capacity stuff that we were talking about to contribute to society at a wider level. If you don't focus on the community, if you're just focusing on individuals, you're stuck then in more of this tertiary level, fix them once they're ill. But also if you fail to notice them, all kinds of horror can happen. So look at it in a wider communal sense.
Correct. And community is essentially still paying the price already, because tertiary level of care, the tax dollar amount is going towards an individual. Can we allocate that tax dollar amount to community as a preventive measure, primary prevention, to, again, investing in the equity of that health to improve health rather than treating the illness? That's the difference.
We always try to finish these with a $9 trillion question, because Oscar and I believe that poor organizational and societal practices are costing organizations in the OECD about $9 trillion sort of annually. You've just upped this to a $12 trillion question. So our $12 trillion question here is, your method of helping people becomes commonplace. It spreads throughout the world. Everybody gets this kind of assistive intelligence help around their well-being. What does the world then look like?
Like they say, stitch in time saves 9, right? It's a $9 trillion question. Now, stitch in time will save $12 trillion. That's what I'm hoping. Again, better world, better times, timely health. I think I call my company, and it's an organization for impact. It's a mission-based company. Dollar is not the end mark for me. Mass adoption is. I want people to get help if they need. I want people to be aware that mental health is important. Well-being, concept of well-being, which was static, of low distress or no distress, should be dynamic. Empowering individuals, empowering communities with resources where if a challenge comes to them, can they adapt to it in a meaningful manner rather than breaking down or chaos happens. Because challenges will be thrown both at individual and community level. We are experiencing it right now. What can we do collectively to change it? So that's my vision again. Getting help to people who need it in timely manner is my vision, my mission here.
So do you believe that that's what you are developing right now can then also bring communities together? Because this is a sort of individual app, right? It's a one to an AI, but do you believe that this may be open the door to other people actually talking more about this?
Yes, we are trying to launch it in India in education system in schools where students, high school, like the statistics today is one student commits suicide every hour in India. There's 32 crore students at risk. So, rather than just, again, making it a stat that another person died, can we start this as a collective screening for all students and catch it in timely manner and save one life at a time? So once we start using it, awareness will happen collectively again. Families will be more open to hearing feedback because it's done in a standardized manner rather than when a teacher says your child is naughty, your child is not paying attention, or your child is misbehaving. It's not a behavior thing. Something must be happening with the child that it's changing. So they'll be more open to understand it and get some help in timely manner. So my hope is once a collective, again, when people start using something, when people start identifying the need of doing something, they may be more open to having a dialogue rather than considering, like in Southeast Asian culture, where talking about mental issues is a sign of weakness, where we're seeking help. They don't even know how to seek help, when to seek help, and why to seek help. So there are so many questions in this world of mental health that maybe I'm crazy that I'm fantasizing such a big issue here. I can tackle my own. I can probably, and I'm seeking help from people like you who also pay attention to it. Spreading the word I'm hoping people will start talking about it without feeling ashamed, essentially, or embarrassed.
On that hopeful note, Nidhi, I think you should have big ideas, right? And think and dream very big. I really applaud you for this initiative, and also like to thank you for your time, Richard as well. Thanks a lot.
Thank you for hearing me out and giving me a platform to speak about my platform.